Hello, everyone. Welcome to the Indigenous Health Topics, sponsored by the Native American Community Outreach Program, which is under Checker with the Mayo Clinic. Today, we are very honored to have Dr. Lee as our guest speaker. Could you go to the next slide, Karina? And just be aware that we will have time at the end of Dr. Lee's presentation over for some Q&A. And then if you would like, you can do your Q&A over in the chat box as well, and then we will discuss it at the end of the presentation. Next slide. So today we are very honored to have Dr. Crystal Lee, who is Diné and with United Natives. And I was very impressed with her bio, but I think her bio really speaks highly. I know that she obtained her Ph.D. from UNLV out in Las Vegas, and she is an assistant professor at the University of New Mexico, and she also holds a master's in public health, and doing some amazing work out in Indian country, and she will be presenting today. The title of her talk is called COVID Impact and Associated Barriers and Solutions in Indian Country, and I'm going to turn it over to Dr. Lee.
Thank you, Trudy. I'm going to take off my mask. That's appropriate. Hey, everyone. I'm honored to be here. My name is Dr. Crystal Lee. I'm originally from Navajo Nation. My maternal grandparents are from a small community in Tisto, Arizona, and my paternal grandparents are from Steamboat, Arizona. My Diné clans are Nata Diné Atachin Inishlan, Nanesh Ejatam Baham Bashachin, Senjikina Dashite, Kinslishin Dashinale. I would like to start off with presenting this video. I was honored and selected to be one of 3 persons in the United States changing health equity. And so therefore, Scientific American did a short 12-minute documentary on the evolution of the work that we are doing in Indian country. I think this video speaks best of the work that we're doing and also the impacts of COVID. After that, I'll do a brief presentation and then open it up for Q&A. So if Karina, would you so kindly please start the video? Thank you.
Can everyone see the video?
Yep. Yes.
Okay, I'll go ahead and start.
There was a lot of death. Every single day, I knew of someone that had passed from COVID, and that does something to you because that's your family, that's your community. Hi, Grandma. In a way, you almost feel self-defeated. Like, how do I help?
That time I was okay. Next day I'm okay. Yesterday evening, he really hit me. It was really hurting on the side. Hurt.
Mentally and emotionally, it definitely impacted me. Sorry. No, just thinking about my uncle who passed, and I grew up with him. He was closer to my age, although he was my dad's youngest brother, but we grew up together, and it hurts, for sure. The Navajo Nation is the size of West Virginia, but yet there's only 13 grocery stores that lie within the reservation. How do you tell a community in the United States that has no running water or electricity to wash their hands? Do they have the financial means to get gas to go to a hospital or clinic? Housing is overcrowded within and among Navajo households. And then you talk about pre-existing health conditions, chronic diseases, also other infectious diseases. And in combination with the outbreak of COVID, it really hit our community extremely hard. My name is Dr. Crystal Lee. First and foremost, I'm a scientist/academic. Both my maternal and my paternal grandfathers were Navajo medicine men. I was 8 years old and in a ceremony watching my grandpa pray for someone. And I remember sitting there in the ceremony and I thought, wow, that's what I want to do with my life. I want to become a doctor and I want to help my people. At the institutions I have been at, I was usually the first Native to graduate. I wanted to see how I can integrate policy with all this health and science, because health policy is such a huge factor on making change. I actually made a recommendation at the United Nations Permanent Forum on Indigenous Issues back in 2018. One of my primary recommendations was they improve international health policies in the event if a pandemic occurred, acknowledging that Indigenous populations globally would be the most adversely impacted. Now you bring us to 2020 when COVID hit the Navajo Nation. My hypothesis was absolutely correct. Historical trauma in our communities has been such a deep and heavy issue for us Native Americans, Alaska Natives, Indigenous people of this land. It was very purposeful to expose us to infectious diseases as a way to commit genocide. And that purposeful act, along with multiple acts, still impacts our health and well-being.
400 something odd dollars a person, it's not enough to provide services in terms of.
For example, when the first round of federal funding came out to assist states to combat COVID, tribes were not included in the first round of federal funding at all.
I hoping I get a different answer, but I talked with him and he said the monies are pretty well spoken.
A big reason why our points of care and our Indian health service system is so substandard is because we get discretionary funds at the congressional level. We are the last to get funded and the first to get cut. That was a huge layer of why it took our tribal communities longer time to react, because we literally did not have the fiscal resources. Part of my academic training is infectious disease and preventative medicine. And when the virus first came out, I understood how the virus was most likely an airborne virus. My nonprofit, United Natives, was the one who spearheaded all of the COVID-19 initial efforts in 2020. And with that, I made some culturally responsive recommendations. For example, as Natives, we burn sage, cedar, and/or sweetgrass. There has been scientific knowledge that if you burn any one of those, sage, sweetgrass, or cedar, that what happens is the smoke weighs down the particles in the air and it falls to the ground. It doesn't kill the virus, but it weighs it down, so it's no longer lingering as airborne. So part of my recommendation to our Native community was If you had someone in the household that's coughing, that you think might have contracted COVID, let's resort back to some cultural preventative practices. Again, there was no scientific knowledge that it worked with COVID, but at least we could try our best to implement some prevention strategies that were cultural based. In addition to that, we delivered masks, Lysol products, in total to about 70 different tribal communities. We partnered with another company temporarily to quarantine Native people. We would pick them up and we secured an entire hotel with over 100 rooms. In March, April, and May, our hotel rooms were completely occupied by people who were COVID positive. Out of the thousands of people we quarantined, only one passed from COVID. And as a result of our quarantine phase, a huge observation was our community members verbalizing that my 14-day quarantine phase is done, I'm COVID negative, but yet I don't have a home to go back to. I don't have a job, I don't have food. I'm a female that's a victim of domestic violence. I don't want to go back home because I'm getting abused, myself and my children are not safe. There was a huge increase in substance abuse, a huge increase in domestic violence, especially among our Native women. And we knew that we had to come up with a plan very quickly. So we ended up turning that hotel into a mental behavioral health facility because of the need. As a result, I started my own company, again, out of need, which is called Indigenous Health. And we do everything from medical health services to mental behavioral health. We opened our doors January 10th of 2022, and Indigenous Health started as a mental behavioral health company to address the gap in need. We have Native American clinicians on our team, and we have evolved into a nationwide company now providing services for the urban natives in Baltimore, Maryland, Washington, D.C., Boston, Massachusetts. We will soon be in New York City, in Chicago, Illinois, in Los Angeles. And we find that these efforts really help our Native community, especially those that are dealing with mental behavioral health issues. And I want to bridge the gap of access to care and quality of care, but not only that, I want to help with bringing culture and our indigenous ways of health and healing and combine it with Western medicine to help our people. What we're doing now, peer support. You know, you've excelled this long in this program. Now you feel that you're able to help your other peers who are incoming to the program, maybe the newer ones.
I have so many ideas, so many things that I want to do for my people, for myself, for my kids. I want to open a business. I want to do cosmetology school. I want to work here. I want to, you know, like, I want to pray.
Native Americans, Alaska Native people do not have health equity. And I do not believe that we will achieve it in my lifetime. However, we can make strides to get there. I had that vision at 8 years old. And for me to be able to live my vision and live my dream, to honor what my grandparents had prayed for, what my ancestors survived, for me to be here in 2022 as a Navajo woman, as a doctor, and to truly give back and help my community. I just really hope my ancestors are proud. I can think of my grandpa and my grandma is looking down and saying, this is what we prayed for. and we're really proud of her.
Everyone, what do you all think of the video? Like I'm talking to two different crowds here, so I don't know which way to look. Hi, good to see you. So I definitely don't want to repeat. I know a lot of us here are Native. We understand a lot of the structural barriers that existed during COVID and after COVID. But for those of us on, especially the Zoom panel, chiming in, a lot of our participants are not Native. So I just want to go over some of the issues that we experienced as structural barriers during the time of COVID. So when COVID hit, our communities were not ready. Our infrastructure is, when I talk about infrastructure, I'm talking about things as simple as roads, so accessibility. I'm talking about access to internet, access to running water, and access to electricity, including heat. We, especially the Navajo Nation, a third of our communities do not have running water, and a fourth of our communities do not have electricity. Also, I believe about more than 50% do not have access to internet. So when COVID did hit, we were already behind of the recommendation by the Center for Disease Control. And what could we do to address the prevention aspect of COVID? We couldn't just wash our hands. And in addition to that, we have households with a large amount of family members, extended family members that live in one household. So pretty crowded in terms of acknowledging how fast the spread could be within one household. And oftentimes our households have elders in it because a lot of our family members do take care of our elders. So acknowledging all these barriers, in addition to the lack of resources, again, access to roads, access to a nearest clinic and or hospital. It could average anywhere from 30 minutes plus to get to a nearest clinical facility. Not that we had enough problems, but also the shortage of healthcare providers. Do we have enough clinical staff? I know a lot of physicians on the front line, for example, Dr. Michelle Tom, who is one of our partners, she's a Navajo physician out on Navajo Nation. She was working 16 hours a day, 7 days a week, assisting with the COVID efforts and acknowledging that we didn't have adequate health care to help provide, especially with the rise in COVID cases. Not also confronting that our healthcare workers were also dealing with mental behavioral health issues. During my consistent communication with our clinical team that we were working with, a lot of them did communicate to me on a personal level that they were combating mental health issues because of all the patients that they were seeing and how much people that the mortality rates were pretty high on Navajo Nation, but yet they still had to persist and care for our community members, and they were not doing well themselves. Not just the physical burnout, but also the emotional and mental burnout was a huge issue for all healthcare workers, but especially if you are a Native clinician working and you're serving your own community and you're serving your own family members, and there's that personal relationship, how much that impacted our healthcare workers. I was in also communication with the Navajo Nation team for tracing when it first started to erupt, when the first cases started to transpire on Navajo and how much the community healthcare workers assisted with this. So because our tribe is so big, for those of you that do not know, Navajo Nation is about equivalent to the state of West Virginia, which is about 30,000 square miles. And because we have the largest land base as a reservation-based tribal land in the US, a lot of our communities are widely spread out. And we just didn't have enough staff resources to assist with COVID. So that's when our community health workers really stepped up and stepped in to assist on tracing and tracking family members. But not only that, but also distributing resources out as well to our community members, because they had those personal relationships with the community as community health workers. And so I think our tribe did a really good job on utilizing what resources we had, although there was a lot of limitations. Now we're talking about staffing issues, we're talking about clinical teams, we're talking about access to even information on the internet, or news, how do you prevent it, what's going on? There was a lot of gaps in communication from a health capacity, healthcare communication that resulted in getting those timely messaging to our community members. Now we're not even acknowledging language barriers at this point. And again, it was the community health workers who really assisted for the pipeline for the communication to coexist during COVID. In addition to that, we're talking about 13 grocery stores in the state, in an area the size of West Virginia, only 13 grocery stores. Now we're talking about basic resources, basic access to water, to food, to PPE. I really commend those people, especially the managers who worked in the grocery stores, because they also had to be really mindful on ordering the supplies. You know, we're talking about, because we could not have a shortage of supplies, because that's just an extra layer of access to resources. So I give also credit to the managers of those stores who ensured that they were readily on top of ensuring that we had adequate access of ordering supplies to those different grocery stores throughout the reservation. And I think just looking at this totality of how we designed without resources, designed this whole infrastructure. Again, I want to reiterate from the video that we did not get the first round of federal funding through the CARES Act. Like, tribes got nothing, and we did not get any federal funding until after the big wave of COVID occurred. And so we already went through the toughest part without any fiscal resources as well. Now we're acknowledging some internal barriers at the reservation tribal level, but then let's also look outside. I want to pose a question especially to people like Mayo Clinic and who work in urban areas or not on tribal land per se, but how does the partnership coexist? Because now we know a pandemic occurred. Now we know that we have to coordinate better partnerships and coordinated partnerships in case something like this occurs again. And the question is, how well and how strong are your partnerships? Is there a policy, internal plan from a organization or company like Mayo Clinic to work with tribes? How are you communicating with tribes to assist on these type of coordination of resources? Not just to private organizations or companies, but also at the state level, at the county level. A lot of states have communicated to myself that they weren't readily reaching out to tribes because they thought that the tribes were being taken care of by the federal government. So because it's out of their quote unquote jurisdiction, they thought we were getting all the help and resources from the federal government, which was not the case. So therefore the states and state organizations were not proactive on working with tribes when COVID did exist as well. So we're looking at now a cross-coordination of resources and cross-coordination of care. I think that this is a teachable moment on how to strengthen this internal, external policy in working with tribes. In addition to that, you know, we're talking about statistics. We don't have true numbers because our data and our surveillance as well, you know, from our reporting mechanism, you know, I think if Navajo Nation is in 3 states, the states of Utah, Arizona, and New Mexico, and then how does the reporting, how well is the reporting surveillance and monitored and administered to keep up with accurate data points? And I think, again, that could be strengthened across states, across county lines, about ensuring that we do have right surveillance, because that will help us with acquiring more resources. It'll help us understand the mortality rates, the prevalence rates, and the incidence rates of any chronic and/or infectious diseases, which also will help with funding, because we need to produce numbers to allocate more resources, and all comes back down to data. And so that is a strong point that I want to make, is data is key to ensuring that we are able to allocate those resources. I have a funny story about this video. The last shot, and it kind of coincides with the structural barriers. I was really adamant to tell the videographer from Scientific American, you have to get a shot of me at my Che and Masana's house, which is my maternal grandparents' house. Very adamant. I was like, that's where I'm really from. Anywhere in the world, this is where I'm from. So I need a shot here. So it was just me and her. There was no one at my grandparents' house. They have since passed. And so it started raining. And mind you, we drove about, my grandparents live a good 30 minutes, all dirt road in the middle of nowhere. And it started raining, and the videographer didn't have rain equipment with her. So we drove all this way to get a shot, but she couldn't go outside. And we just were parked there. We're like, okay, we're 2 smart women. We could figure something out. How do we get a shot? So I'm like, I know, there's an outhouse right there. I was like, go run in the outhouse and sit in there and you can shoot me because it'll protect you. This New York City woman that lives in New York City is a videographer, and herself was sitting in the outhouse shooting my last shot. And we were laughing so hard, I would say. But, you know, and for her to understand, because just her to see the geographical layout, how far it took to get to my grandparents' house, how that we still use outhouses because my grandparents' house has no running water, you know, but I'm going to remember that forever. But we became innovative that day. But I say that to say that we have so many structural barriers that also include policy. As I indicated, I'm part of the United Nations. I do a lot of human rights advocacy on behalf of Indigenous peoples. I've been doing this since I was 27 years old. And my consistent recommendations have to do with human rights and Indigenous issues. And understanding, you know, international health policy, again, how do we work with other countries because of our traveling, and the exposure of infectious diseases. And we have to strengthen our also international policies as well, not just at the tribal level or the state and tribal coordination or the tribal and federal, but also international policies as well, because some of our tribes are international on both sides of the United States and Canada, right? They have lands and on both parts, so they're considered international citizens of both the U.S. and Canada. And also there's some tribes that also have that cross coordination between the United States and Mexico, so they're dual citizens. And that impacts us too at the tribal level if they're dual citizens in both countries. And then how do we work within those systems for those types of policies as well? And so just to bring up how important policy is, I really don't want to talk a whole lot. I also want to leave a lot for Q&A. But Karina, could you please start the PowerPoint? I just want to briefly go through some of the work that us and our team is doing, and then we'll go ahead and open up for Q&A. So in the video, I indicated that we did quarantine. We were quarantining people, and as a result, people did not want to go home after the 14-day quarantine was ending because of unsafe housing, increase of substance abuse, increase of domestic violence, insecure housing, and also food insecurity. And because we fed the people 3 times a day. And this resulted in the mental behavioral health portion of the ripple impacts of COVID. And that's how Indigenous Health was initially started. And can we go next slide, Karina? So we have 2 sectors of what we do. We have our Indigenous Health Company, and we also have our nonprofit United Native sector. And they work hand in hand to assist our communities in multiple ways, not just in the space of health, but also basic resources that we're providing. Next slide, please. So Indigenous Health and United Natives work together. So Indigenous Health focuses on mental behavioral health services with some aspects of direct medical health care and also prevention education. And then our nonprofit sector provides supplemental housing, cultural-based activities, and community outreach and engagement and activities as well. Next slide, please. So when COVID hit, our nonprofit sector allocated a few $1 million. There were a lot of people doing good work out in Indian country, and a lot of different organizations and a lot of people who are proactive on helping with PPE and supplies. There were other, whether they were community members or chapter houses, but we work directly with the chapter houses, and we obtain a direct contact with Lysol. At the time, I believe I was the only tribal organization that had a direct contract with Lysol. So we secured a whole warehouse in Flagstaff, Arizona that was donated to us. And we had hundreds of pallets of Lysol, both wipes and the spray that were disseminated to over 70 communities among the White Mountain Apache, Hopi, and Navajo communities, both Arizona and New Mexico side. Next slide, please. We were delivering supplies throughout, myself included, was driving a big U-Haul on the dirt road in the middle of nowhere. We even got a flat tire and out in the dirt road in the middle of nowhere. But we had a great volunteer-based team. Again, we were working with frontline clinicians and other volunteers who really helped to obtain the supplies and help disseminate it throughout Indian country. Next slide, please. Just some more pictures of some of our relief efforts. And you can just skim through the next 3 slides briefly. All the communities that we hit are some of them. and where our donations went. We're actually featured in USA Today as one of the leading nonprofits helping Indian country during COVID. Next slide, please. So, sorry, next slide. Just to give some statistics for those of you that might not know, this data is Native and/or Navajo specific, that we have psychological distress compared to white Americans 2.5 times higher in comparison. We also have the highest suicide rates in different age ranges. As you could see here, the suicide death rate is more than double than non-Hispanic whites. In addition to that, in Navajo Nation in 2016, there were a documented total of about 211, but these are not real numbers. Again, I believe the numbers are much higher because of the data. And I know especially like in Pine Ridge area, suicide rates are extremely high, higher than Navajo Nation. I believe the highest in the country, per cases per population capita. And next slide, please. So we're talking about, you know, as Natives combating a global pandemic, but also understand the historical context, right? Because this is not brand new to us with the psychological distress of infectious diseases, especially when they were exposed to us purposely, historically, to eradicate us as people. So there's also deep roots of trauma in our experiences. It just wasn't the pandemic that absolutely traumatized the entire world, but it especially traumatized Native Americans because of our historical experiences with purposeful exposure to infectious diseases. When our ancestors went through this experience, we have to understand that there is such thing called epigenetics. And epigenetics is basically, it's embedded in our DNA. Both resilience and both traumas are embedded in our DNA. That's housed there. So we also have had within our DNA through epigenetics that is a more new wave of scientific findings, is that all of us house our ancestors' DNA, of course, but also within those DNA threads that we also hold the genetics and also their experiences, which is levels of historical trauma and also levels of resilience as well, right? But to understand the relationship with our past to current, that's literally in our DNA, and you know, and how that adversely impacted our communities, not only from a physical aspect, but also in a mental and emotional aspects as well, because it's a reminder, again, that was prompted, whether we know it or not, consciously or unconsciously, that this is another layer that we also had to deal with. Next slide, please. So because of the need, during COVID, just the lack in general of clinical staff on or around reservations, or even in urban communities that work in our tribal clinics, I've recognized that we don't have enough staff, and we need to train more Native healthcare professionals. And I'm just lucky to have our team of Native healthcare professionals that have joined alongside this journey to help our community members. I have developed Indigenous Health because, again, out of need. about 98% of our clinical team are Native American. We subcontract with different healthcare specialists as well throughout the country via telehealth. So our headquarters is in Tempe, Arizona. Our housing is through our nonprofit sector, which is United Natives, that is in Mesa. But we are working with all these communities in Las Vegas, in New York City, in Chicago, in South Dakota, in Boston, Washington, D.C., and Baltimore. And we are doing telehealth with all these communities nationwide. Number one is a lot of our community members want to see Native healthcare providers, especially Native therapists. We have licensed therapists sitting here that are Native, and that's the number one request from especially our urban areas. So our team, not me, I'm not a licensed therapist, but our team does a really good job at coordinating the healthcare services via therapy to our people nationwide, and working with our different facilities that we have. Next slide, please. These are just a few of our scopes of services that we integrate into our healthcare systems. One thing that we do really pride ourselves on is the re-engagement of spiritual Native health healing and spiritual revitalization. A lot of our community members that are dealing with substance abuse don't have that connection or knowledge of the cultural aspect. So we do work with different medicine men and from different tribes. One thing that was novel about what we're doing is how do we do telehealth there? How do we do telehealth with medicine men? This is something that has never been done before. And then I had to talk with our team, like, how do we do this appropriately so it's respectful, like to ensure that the patient does not record sacred songs or prayers. So then we had to come up with an NDA, a non-disclosure agreement, because it's telehealth based, and there's based on the medicine man, could he help everyone, or is the medicine man going to be tribal specific to only help people from his community? Are they going to be open? So we had to come up with all these scenarios that's never been done before via telehealth to work with the integration of our spiritual healers and by way of telehealth, which has been interesting for us to work with. Next slide, please. Just a few more of our services, and we could go on. One thing that we're doing is we're also creating an Indigenous Health app. We've been working on this app for over 2 years, so I hope to get it out soon. So this app is going to have 4 major sectors, which will be telehealth, the ability to provide telehealth services using the app. We're going to have a self-monitoring phase, so you can self-monitor your own health status. We're going to have a research phase. We want to work with Indigenous researchers and provide a space where they can output surveys in relation to their research. But me as a researcher, I'm going to be very selective on what type of research that we are doing, and especially who the researchers that we're working with, because I want to work with Native American researchers and/or Indigenous researchers, and because I believe that we can lead our own studies. But this will be an additional platform to provide data allocation for them, whether it's qualitative or quantitative data. And then we're going to have a resource and information page. So people like Mayo Clinic, Native Health, etc. We definitely, and others, we definitely love to invite you all to put your information on the resource and information page as well. Right now, we do have every Indian Health Service clinic or funded urban health clinic, or 638. We have them all throughout the United States, all the information on the app. So you could just click on, and then it'll bring you to your nearest native clinic. So it's easy to navigate. And with Navajo Nation, we're doing one specific for Navajo Nation that has all the numbers and information for social services as well. Because sometimes you don't know who to get, how to get them. They're so sparse, and it can be trouble getting the resources. All the information will be on the app. And then we also have an elder wood program through our nonprofit. You know, it's really cold. Again, lack of electricity, which is lack of heat. A lot of our community members rely on firewood to heat their house. So we have an elder wood program. We have a team of volunteers that are based in Flagstaff, and we have delivered over 600 truckloads of wood out into the community. We also work directly with the chapter houses, and then the chapter houses redisseminate out to their community members who know that need the wood. So through our nonprofit, United Natives, we have a free wood program. If you all are interested, please let me know, because it really helps for especially our elders. Next slide, please. Just some more pictures. We also have a water program that functions like our wood program. So we disseminate both water and wood to the more rural parts of the reservation. Next slide, please. Just more pictures. Look at all the work. We have different community-based activities, back to school drive. Next slide, please. Our nonprofit sector did a football camp that was conducted by UCLA football team this past summer. We had over 200 Native kids come. It was here at Mesa. We're also partnered with the Arizona Cardinals, the Phoenix Suns, the Arizona Coyotes, the Las Vegas Raiders, and soon to be the New York Knicks to help tribal communities and especially youth engagement. So please look out for some of our services. And then we also have a Native American scholarship program. So our college students, we disseminate $2,000 each semester for those who are recipients of our scholarship program. Okay, I think we're done. Now we'd like to open up for Q&A.
Do you have anybody in the room that has questions, first of all? Trying to get questions
Judy.
lined up.
You mentioned the app, the location for the IHS at 638. Because at the Mayo Clinic, we work a lot with natives. So I'm just curious, is that across Turtle Island or predominantly Southwest? Because we serve natives across Turtle Island as well as Alaska natives.
It's throughout the United States. So this app has every clinic, hospital 638 that is IHS funded or tribally funded throughout the U.S. That was our starting base, but of course we're always open to adding more resources, especially to those entities that serve Indian country. It's a great resource.
What would be your suggestion or I guess your suggestion to Mayo Clinic to reaching out to tribal communities and to build that partnership with them? What would be your advice, I guess? How can they be better at doing that?
So the question is, how can Mayo Clinic, what is my recommendation to Mayo Clinic to establish these partnerships? Number one, I always lead with transparency. I think it's very important on the the reason why you want to partner with us. And I think every reason is important. Is it because you're trying to strengthen your diversity and inclusion? Is it because you all got a grant and you need, and it's written for certain populations? And I think all those things are important to communicate and be transparent across the board on why you truly want to partner, but then also what are additional things that you could offer in terms of the partnership and what does it look like? How does it benefit the tribe, not you? I think that's a leading way, because we have to think about the communities that are under-resourced, which make them make us vulnerable because of our limited resources as well. And I think as Native people, we're tired of people taking advantage of our vulnerability. And it should be us to self-determine based on the information that is derived to us if we want to make that partnership agreement or not. But give us all the information so we can make a true informed decision on what this partnership will look like.
All right, there's another question online, Dr. Lee. So earlier in the chat, someone had posted, "Thank you for sharing all the amazing work you are doing to support Indigenous communities across Indian country." Their question is regarding the US President's end of emergency COVID declaration that will end in May 2023. Is there work being done to help Native health organizations with the changes that may impact costs and care to American Indian and Alaska Native populations?
This is pertaining to the US government, correct?
Yes. And the
Okay.
end of the emergency COVID funds.
I think this administration is doing a better job than last administration of federal funding. What I do know is they're trying to make the federal funds that parallels with the output of the VA system, because the Indian Health Service functions like the VA system in the aspect of it's federally funded and it provides direct healthcare services to veterans across the nation, kind of like IHS. The only difference is the VA funding is a lot better in terms of its consistency, because, and they also keep up with inflation, which Indian Health Service dollars do not, because they're considered discretionary funds. So I know that there is commitment to having our federal funding more consistent and also increase that keeps up with general inflation as well. I haven't learned where they are with that, but I do not know any other thing that this administration is currently doing in terms of US policy and working with tribes.
Hey, Dr. Lee, thanks so much. A couple more questions in the Q&A here. So question one, how did an individual start the process of becoming involved in human rights impacting Native Americans? Is there a requirement to move back to the reservation to continue with this endeavor?
No, you don't have to. You do not have to be on the reservation to either be an ally or to be a supporter. There are, what I do know in a lot of urban areas, I know there's different initiatives that Natives are centering around. One of them is definitely the missing and murdered Indigenous women, addressing that epidemic, which incorporates a lot of other human rights issues, not just the act of homicide or kidnapping, but also the aspect of, sovereignty, criminal versus civil cases that that can or cannot be done on tribal jurisdiction lands. And it brings up a lot of other political issues as well. So I know that a lot of people are getting behind that initiative. Also, access, I know there's a lot of water rights coalitions that also occur, which affects us because of our lack of water and our access to water. So these environmental rights are largely supported by tribal initiatives and also our allies. But there's a lot of support that could be done in different arenas. My suggestion is probably just look at Facebook groups to start in your local area and see what initiatives are going on in those that you want to get behind.
Awesome, thank you. I have a couple more a little more in the housekeeping side of things. One is a number of folks have been asking if you'd be willing to share your PowerPoint presentation that you delivered today. And then two, in regards to the app, does the app support languages other than English?
We're trying to get there. we are, that would be another added layer that we could definitely work on in the future. I think starting with the Diné language, that could be, especially medical terminology, that could be used for translation, would be an added feature as we evolve with the app. I mean, the app itself is extremely innovative because it's definitely a resource. And we're not just going to use this app. We're using a pilot nationally, but we're going to hope to go global and work with other Indigenous communities, particularly First Nations in Canada, the Maoris in New Zealand, and the Aboriginal folks in Australia to expand on and working with our international brothers and sisters. But yeah, we hope, follow us on our website and our Instagram page, and we can, we'll be having a date that everyone can download the app. Another cool thing about this app is we want to work with the Missing and Murdered Indigenous Women Initiative. By way of doing so, people can report some of their missing relatives to us. We will need a standard missing police report so we know it is valid. If they supply us with the police report, we can then, for everyone who has the app downloaded, we can send almost like an Amber Alert message out, like a text message through the app, so we could have the information of the person who went missing, and that could hopefully be a way to reach people in real time quickly to help find missing relatives.
One more app question and I'll quit, promise. Is it free?
Yes, it's free. I just need a piece of fry bread. Hey. Send me a bag of flour. Kidding.
All right, awesome. Are there any more questions in the room? All right. It is the end of the hour. I just want to thank you again, Dr. Lee, for that really awesome presentation. There were a lot of comments, just everyone appreciating all the work that you are doing, and then especially about the app. It sounds really exciting, and we're all looking forward to seeing that. So thank you again. And I just want to remind everyone, if you could all please complete our short survey to provide feedback on our speaker series. And if you would like to see this presentation or any of our previous presentations, I know we did drop our link in the chat, but it is under our Native American Community Outreach website here at the Mayo Clinic. We will have an upcoming presenter in March, so stay tuned. You should all see some email invites coming out soon. And I just want to see if you have any last words, Dr. Lee.
Just would like to thank our team, our Indigenous Health team that's sitting here today. They're the ones that do a lot of the work, and I just talk. So Dr. Ebony Granados from the Lakota Nation, Mr. Fidel Curtis from the Diné Nation, and Mr. Justin Arnold from the Seminole Nation. I just wanted to thank our team because without our team and teamwork, and especially from the community as well, this wouldn't be possible. So just wanted my true appreciation for everyone.
All right, with that, I will go ahead and stop recording and sharing here. So thank you again, and you guys enjoy the rest of your day.